Dekat bawah.
You will love Malaysia now and forever. Different races everywhere. The soul of Asia is surely here. This beautiful Malaysia. You will love the colors of Malaysia, where the sun loves to shine.
In the rapidly evolving world of medical science, constant learning is a necessity of life for today's laboratory professional. Introducing AACC Learning Lab for Laboratory Medicine on NEJM Knowledge Plus, the first continuous learning platform designed especially for laboratory medicine professionals.
Adaptive learning is a way for a learner to focus precisely on his or her needs. In many ways, it's the same as what precision medicine is for treatment of cancers, where you can focus a treatment specifically on an individual's needs.
This curriculum-based program, when completed, it will contain 120 courses that span across all disciplines of laboratory medicine. So it becomes the de facto backbone of all training programs in laboratory medicine.
The courses are developed by domain experts in the field. The experts all come from top universities in North America, and they are all lab medicine scientists or physicians. The advantage of the product is that we can update content once new guidelines have changed, new relevant science published.
Each month, your subscription provides you brand new material designed to help you increase proficiency and stay current. Behind every question is a way to dig deeper into the content. Every answer includes resources that explain the concept in detail, along with illustrations, tutorials, and references to further reading. You can fit learning in whenever you have a free moment, from your desktop, tablet, or phone.
The platform is very easy to use. Within seconds of logging on, I'm up and running. The course is designed in such a way that it adapts to me, and I constantly feel challenged. It kept me engaged, and I came away from the experience feeling that I'd actually achieved something.
This program targets all professionals in laboratory medicine and will prove invaluable for those preparing for certification exams, those seeking medical education credit, and those desiring to assess their competency.
When I look back, I honestly wish that I had access to this program when I was a trainee.
This program is a collaboration between AACC, the leading authority in laboratory medicine, NEJM Group, publisher of the New England Journal of Medicine, and Area 9, a global pioneer in education technology.
When you think about it, the impact could be transformational.
Sign up is easy. Simply go to aacc.org/learninglab, pick subscribe, then select a course and start learning. With AACC Learning Lab for Laboratory Medicine on NEJM Knowledge Plus, you can learn anywhere, anytime. Sign up today.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullah, and a very good morning to all participants of 32nd MCB Annual Conference. My name is Rosie, and I'll be your MC throughout the conference. You can address any inquiries or questions to me, or simply type them in the chat box on the taskbar on your screen. There are many interesting and beneficial lectures that are lined up these 2 days, and we look forward to your active participations. You can type your questions on the Q&A box, or just raise your hands and we will direct you to the speaker. And if time permits, we can have an active chat with the speakers before the next lecture. Also take note that all the lectures are not continuous, so you need to leave at the end of the session and click on the next box or next session to join. We also appreciate if you can fill in all feedback forms at the end of each lecture. We also have a few breaks in between lectures, and also during lunch break, we would like to invite everyone to visit the Expo and MACB booth to see the latest updates and news from our sponsors and vendors. You can click at the taskbar on your right. The MMA CPD and my CPD code, QR code will be projected at the end of the conference. Now I would like to invite Mr. Fahim to the floor to recite a short dua before we start the conference. Mr. Fahim, the floor is yours.
To be Allah, Lord of the worlds. Let your blessing and your peace be on your servant and your messenger Muhammad and on his family and his companions. Allahumma ya Hafizun ya Raqib. In this glorious morning, in conjunction with the 32nd MACB Conference 2022, we uphold our hands to pray gratefully to thank on your infinite favor to us till we can live in peace and harmony to perform our tasks as your servant. O Allah, we seek your blessing for a flawless progress of this event from beginning till the end. We seek your guidance to steer clear of the event and make this occasion a success. O Allah, grant us with a valuable knowledge that will be beneficial to mankind in order to gain your mardatillah. Allahumma ya Hayyun ya Qayyum ya Dzal Jalal wal Ikram. You are the mercy of the mercious, and you are the Lord of the universe. Give us mercy from your presence and shape for us right conduct in our plight. We ask you for knowledge which is beneficial and sustenance which is good, and deeds which are acceptable. O Allah, help us to remember you, to thank you, to worship you in the best of manners. Forgive us, have mercy upon us, guide us, give us health and grant us sustenance. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. وصلى الله على سيدنا محمد وعلى آله وصحبه أجمعين والحمد لله رب العالمين.
Thank you, Mr. Fahim. Please join me now to welcome our Honorable MACB President, Yang Mulia Raja Dr. Elina Raja Azudin, to deliver her welcoming remarks. Doctor, the floor is yours.
Thank you, Puan Rosila. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning. Friends, colleagues, ladies and gentlemen, it gives me great pleasure to welcome you to the 32nd MACB Conference 2022. Thank you very much for joining us at this event. This year, the MACB Conference is a 3-day event where a pre-conference workshop on POCT was successfully conducted yesterday. The conference, which carries the theme Integrated Approach in Medical Laboratory Challenges and Opportunities, is the 3rd year running where the MACB conference is held via a virtual platform. I'm pleased that for this year's conference, we have an interesting scientific program which covers various topics of current interest in the field of laboratory science. Topics include personalized medicine, quality management, integrated diagnostics, and clinical updates in various disease areas. These lectures will be delivered by eminent speakers who are experts in the field, and I hope all participants will enjoy the scientific program and will be able to apply the knowledge learned during the conference. This year, the MACB has, for the first time, held a Young Scientist Award competition. I take this opportunity to congratulate all 5 award winners. It is in MACB's plan to make this a yearly competition with the aim of encouraging more young scientists to present papers on their ongoing research. As the situation of the global 19 pandemic is gradually improving, the MACB has held 3 physical workshops in 2022, and more workshops are planned in 2023. We also look forward to hosting the 33rd MACB conference in 2023, either physically or in hybrid mode. The MACB will do its utmost best to provide travel grants to physical attendees in next year's conference. Updates and announcements on these events will be made available via the MACB website. The MACB will also be launching the AACC Learning Lab, which is an adaptive learning program on its website. For your information, the MACB has been a member of the APFCB and IFCC since 1991. I take this opportunity to thank the APFCB for granting its auspicious to the 32nd MACB Conference 2022. I would also like to take this opportunity to congratulate the IFCC on its 70th anniversary. The MACB looks forward to continuing support and ongoing collaboration with the APFCB and the IFCC. Before I end, I would like to congratulate the organizing committee for the splendid job in putting together a great conference. Finally, I would like to convey my heartfelt thanks to all those who have contributed to the success of the conference, in particular, Dr. Nolida Harun, who is chair of this conference, Dr. Nurul Amin Firdaus, and all members of the organizing committee who have worked very hard to make this conference a success. My thanks also goes to the speakers, the sponsors, the exhibitors, and the MACB Council, and all those who have contributed to the organization of this conference in one way or another. I wish everyone an enjoyable conference. Thank you. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rajalina. I would now like to call upon Dr. Nolida Harun as the chairman of the 32nd MACB Annual Conference to deliver her opening speech. Dr. Nolida, the floor is yours.
Bismillahirrahmanirrahim. Dear peers, colleagues, and friends, I am Dr. Nolida Harun, the chairman of the 32nd Virtual MACB Conference. Assalamualaikum and good morning, everyone. We are very lucky today, even though physically we are somewhere in the world, but we are united at this 32nd MACB Virtual Conference. On behalf of the organizing committee, it is a great pleasure to welcome all of you to the 32nd Malaysian Association of Clinical Biochemists Virtual Conference that is being held from 12 to 13 September 2022. The 32nd MACB conference will be a great opportunity to update your knowledge in the clinical biochemistry and medical laboratory field. It virtually gathers local and international scientists, medical laboratory technologists, academicians, researchers, students, and exhibitors using the Zoom platform. The conference is offered at a very reasonable fee. The recorded lectures can be accessed within the 30 days, and participants will be awarded an online certificate. Thank you to everyone for supporting this conference, which has successfully gathered approximately 250 participants. The theme of the 32nd MACB conference is Integrated Approach in Medical Laboratory, Challenges and Opportunities. This conference offers a variety of recent and relevant topics in the field of clinical biochemistry and laboratory medicine that will be divided in 11 lectures and presented by expert local and international speakers. Thanks to all the speakers for accepting our invitation and joining us in this conference despite their busy schedule. Ladies and gentlemen, for your information, this is the first year the Young Scientist Awards is being awarded by MACB. We are very happy to receive a very good response for the Young Scientist Awards poster and oral presentations. They will share with us the insight of their current research through their e-posters and oral presentations. We also would like to thank the sponsors for their support of the conference, and they will share with us their cutting-edge technologies in laboratory medicine during the industrial workshop, virtual booth, and advertisement sessions. You can scan the QR code for the detailed program of this conference. Finally, I would like to thank the organizing committee for making this conference happen within the short time span and hope it will be a great success. I'm sure the 33rd MACB conference next year will be held physically. I'm looking forward to another excellent virtual meeting with all of you today and tomorrow. I hope the conference will be a great success and be a good knowledge sharing platform for all the participants. And then, till then, enjoy your time with us for this today's conference, and thank you.
Dr. Munira? Okay, can everyone hear me?
Yes.
All right, okay, sorry about that. Okay, well, now we can kick off with the first lecture today from Dr. Munira Mansoor on endocrine, what's the latest? Let me introduce to you a bit on Dr. Munira Mansoor. She is a chemical pathologist and obtained her medical degree from University Malaya in 2007. She attained her Masters of Pathology from University Kebangsaan Malaysia in 2016. She was then serving with the Ministry of Health Malaysia for 9 years before joining Hospital Chancellor Tuanku Mukhris UKM in 2017. Currently, she holds a few administrative posts under the hospital, which are Head of Chemical Pathology Unit and Head for Department of Diagnostic Laboratory Services. She's in charge for Department of Diagnostic Laboratory Services in COVID-19 management among healthcare workers. She's also a member for credentialing and medical privileging for the department. Dr. Munira is actively involved in the undergraduate and postgraduate teaching as facilitator and supervisor. Dr. Munira, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. I am Munirah Mansur from Hospital Chancellor Tuanku Mukhris, Pusat Perubatan UKM, or also known as UKM Medical Center. I would like to express my thanks to the 32nd MACB Conference Organizing Committee for the opportunity given to me to deliver a lecture entitled Endocrine, What's the Latest? My approach is more like a symposium. I will cover a few topics in relations to endocrine. I will start off with updates on Malaysia clinical practice guideline, especially on type 2 diabetes. I will proceed with review on hyperprolactinemia and complete with guide and recommendations in interpretations of somatotropic axis and corticotropic axis. I will start off with the clinical practice guideline on type 2 diabetes mellitus, which is the 6th edition that was published on December 2020. Just a recap on type 2 diabetes mellitus. As you can see on the diagrams of pathophysiology of type 2 diabetes, there is availability of insulin. However, the cell fails to respond to the insulin properly. This is because of the insulin resistant states that results in the hepatic glucose output increment and reduce in the utilization of glucose by various organs, which lead to fasting hyperglycemia and between meal hyperglycemia. Apart from that, there is impaired intestinal incretin secretion that cause compromised milk-related insulin secretions and glucagon suppression, contributing to postprandial hyperglycemia. Lastly, excessive renal tubular reabsorptions of glucose, which further contributes to the hyperglycemia. Thus, in a nutshell, type 2 diabetes mellitus is defined as progressive decline in beta cell functions that is associated with insulin resistance in muscles and adipose tissue. I would like to highlight on prevalence and terms in regards to type 2 diabetes. As we can see that in type 2, in this current CPG, they put more emphasis on pre-diabetes state as well as in adolescent. So what is pre-diabetes? Pre-diabetes is elevated plasma glucose levels that falls below the threshold to diagnose diabetes. And the rest of the terms, impact fasting glycemia, impact glucose tolerance, and diabetes mellitus, were based on the diagnostic value on the glucose results. For example, in impact fasting glucose refers at baseline on the fasting levels of range from 6.1 to 6.9, Meanwhile, for IGT, impact glucose tolerance, we refers to the 2 hours postprandial or after OGTT, which the range is 7.8 to 11. Lastly, on diabetes, based on both value at 0 and 2 hours postprandial, which is more than 7 millimole per liter at baseline, and at 2 hours more than 11.1. Kindly look at on the right hand side of the table a comparison on data NHMS data on 2015-2019. We can appreciate an increasing percentage of all the respective criteria of diabetes, whether it's established, undiagnosed, and overall. We can appreciate that roughly the increment range of about 1 to 5% of differences. And the lower table, table 1.1, is the prevalence of overall diabetes based on the ethnicity for adults of more or equals to 18 years. This slide shows the testing criteria for women with history of diabetes, adults who are overweight or obese with metabolic parameters of BMI more than 23 kilo per meter squared, waist circumference of more than 80 cm for women and 90 cm for men, with possible risk factors that may portray or may confer a risk to develop type 2 diabetes. For example, like history of cardiovascular disease, primary relatives of type 2 diabetes, hypertension, dyslipidemia, women who have delivered baby of weighing more than 4 kilos, and those who are born from mother with gestational diabetes mellitus, and other endocrine problems in relations to insulin resistance, for example, Cushing syndrome, acromegaly, PCOS, pheochromocytoma, person with physical inactivity, sedentary lifestyles, and those who are in receiving long-term treatments of any medications that actually promote hyperglycemia state, for example, corticosteroid, antiretroviral therapy, antipsychotic drug, thiazide diuretics, and so on. And for those individuals who under pre-diabetic group, which are based on the A1C range of 5.7% to 6.2%, IGT or IGF should be tested yearly. Kindly refers to the tables 2.2, where it highlights on the criteria testing for type 2 diabetes in adolescents. They propose that screening should be performed in adolescents who are overweight, which signify at 85 percentile, and obese at 95 percentile, and have one or more additional risk factors such as maternal history of diabetes mellitus or gestational diabetes mellitus during child gestation, family history, type 2 diabetes in primary relative, recurrent abscess of pruritus genitalia, signs of insulin resistance, as described earlier. And if all the tests are normal, and they suggest of repeat screening at minimums of 3 years intervals or more frequent if the BMI is increasing. Okay. The value for diagnosis is same as previous CPG, and I hope everybody can remember on the appropriate value so that we able to discriminate and identify and rectify on the value accordingly. I would like to share on the A1C based on the CPG. They enforce on the individualized target based on the patient profile. So if you refer to table 3.6, okay, I will put as an tight control for those who are just diagnosed, younger age, who actually have a lifelong expectancy with no cardiovascular complications and that's not on medications that may cause hypoglycemia. Meanwhile, a less tight or less loosened target for those patients who are elderly, who actually suffered from comorbidities and actually more prone to suffer from hypoglycemia. The intervals for measurement was suggest as 3 to 6 months for those who are in unchanging therapy. Meanwhile, for 6 monthly, for those who actually have a stable A1C and glucose lowering therapy. A bit on A1C reporting. The CPG encouraged the report as such, utilizing NGSP, IFCC, as well as estimated average dose, or a combination of any of the three. Because of the A1C itself has a limitation, and you may refer to table 3.21. There are a lot of factors that may affect A1C value. Some patients may have a higher A1C values, for example, like rapidly improved diabetes, iron deficiency, older age, vitamin B12 deficiency, hypothyroidism, and some patients may have a lower A1C, for example, in a sudden onset of exacerbations of diabetes, from a recovery from the iron deficiency anemia, hemolysis, blood transfusion, recent anemia, during renal anemia during treatment with erythropoietin, liver cirrhosis, or equivocal, either higher or lower A1C for those who are having suffered from hemoglobinopathies, or based on the ethnicity. For example, like Indian and Malay may have a higher value. Meanwhile, for Chinese, they tend to have a lower value. And it was possible because of the medication. Because of this, the CPG highlights on the glycation gap. Okay, what is glycation gap? It is defined as the difference between the measured A1C and that which we predicted from other tools of glycemic control. And knowledge on glycation gap improves the quality of monitoring of the glycemic control, especially for those patients who A1C level do not reflect the mean blood glucose level. Because of the presence of discrepancy, CPG suggests alternative method to consider by self-monitoring blood glucose, which is preferably quality controlled, as it able to provide a capillary glucose profile, which is more ideal and practical method. Another options to consider is total glycated hemoglobin estimation. As improvement in A1C measurement, POCT is one of the tools that can be utilized for A1C measurement, POCT device. And to note that it is not for diagnostic purposes. The sole purpose is more for monitoring. And with improvements in the analytical performance of the device, we able to appreciate the cost-effective tools in A1C monitoring, improvement in the quality of life, reductions in waiting time in clinical visit, improvement in remote area accessibility, and the suitability in a pediatric patients because it's use minimal blood taking. Fructosamine estimation. As we all know, it has a full correlations of fructosamines to average glucose, and it's actually an option in a patient with inaccuracy of A1C measurement because of the possible causes that may interfere or may alter the A1C measurement. And fructosamine reflects a glucose control of 2 to 3 weeks. Options that a patient can have to monitor the blood glucose is by individual monitoring via SMBG or CGM. CMBG should be recommended in patients who are on insulin, and it is desirable for those who are on oral glucose lowering drugs. And CGM should be considered in patient who has a suboptimal A1C target and or suspected to have unrecognized hypoglycemia who on intensive insulin therapy. I would like to address everybody on the metabolic complications of the type 2 diabetes, which is the metabolic associated fatty liver disease, previously known as non-alcoholic fatty liver disease, which is highly prevalent among type 2. And type 2 diabetes mellitus is also a risk factor for more severe NFLD, and the mode of prevention is via lifestyle modification. And some patients may require statin to treat the dyslipidemia as well as to reduce cardiovascular disease risk. And patient who suspected or confirms to have more severe non-alcoholic fatty liver disease should be considered for a referral to gastroenterologist or hepatologist for further evaluations and management. So how do we tackle on the last point of view is by using FIB score to assess the severity or the potential of NFLD. So we utilize the AST, ALT level as well as the platelet count incorporated with the age and accompanied with the ultrasound to diagnose fatty liver or exclude focal liver lesions, and to exclude as well other possible causes that may cause elevated ALT or AST ratio. So the cutoff point that being proposed is less than 1.3 will be interpreted as low risk for advanced fibrosis. More or equals to 1.3, it interpreted as intermediate to high risk for advanced fibrosis. So for those patients under the group of more or equal 1.3, they will underwent radio imaging to further assess on the liver integrity, especially on the stiffness. Okay. Liver biopsy can be considered to diagnose NASH, the sequelae of NFLD, steatohepatosis, and for those who actually have a persistent elevated ALT, OST, and patient who has elevated liver stiffness measurement. Lastly, on CPG type 2 diabetes is on euglycemic ketoacidosis. It is considered as additional terms on ketoacidosis, as previously it is commonly described in type 1 diabetes and in pregnancy. So nowadays we are looking at the occurrence of euglycemic ketoacidosis in a patient who use SGLT2 for treatments of type 2 diabetes. It has approximately about 10% of patients with DKA present with a near normal glycemic value. And the terms euglycemic, obviously it refers to a plasma glucose less than 11. However, based on the clinical presentations, some of the patients may have a blood glucose of more than 11, which range from 15 to 17 millimole. Now I will move on to review on hyperprolactinemia. We will look at the prolactin biochemistry and physiology in order to understand the laboratory approach on the possible causes of hyperprolactin. So, prolactin, the function is to control lactation, and it is synthesized and secreted by the anterior pituitary. It is encoded in chromosome 6 with two types, pituitary PRL prolactin and extra pituitary prolactin. Prolactin has a strong structural homology to growth hormone and placenta lactogen. It has different isoforms called little, big, and big, which are referring to the molecular weight of the isoform, ranging from the little one, 23, big, 48 to 56 kilodalton, and big of more than 150. So from the circulating prolactin, the highest components or highest percentage would be the little, followed by big and big prolactin. A bit knowledge or info on the little prolactin, which we refer it as monomer prolactin. It has three variants, 14 kilodalton, 16 kilodalton, and 22 kilodalton. There is increased research on the 60 kilodalton that it has a role in inhibitions in angiogenesis, prepartum cardiomyopathy, and preeclampsia. Table 1 showed potential causes of hyperprolactinemia. We can look at the analytical hyperprolactinemia, also called as macroprolactinemia. Physiological may be due to pregnancy, lactation, stress, pharmacology. We have a potential list of drugs, especially antipsychotic, antidepressant, and estrogen, OCP, pathological by adenoma, problems or disorders of hypothalamus and pituitary, renal failure, liver failure, hypothyroidism, and idiopathic. Idiopathic is diagnosis of exclusion, meaning that we need to exclude the rest of the possible causes of hyperprolactinemia before resorting to idiopathic in nature. Measurement of prolactin by immunoassay to cite immunometric sandwich. The assay is standardized to WHO International Prolactin Standards of 20 kilodalton derived from human pituitary. There is a full agreement of inter-vendor, but it's dependable. And the reference interval is a platform specific, but as we know, as expected value, male should be low than female. Male less than 40 microgram and female is less than 24 microgram per liter. Laboratory approach on hyperprolactinemia. Based on Endocrine Society, it is recommended that single measurement is enough, which is obtained at any time of the day. We need to rule out physiological, drug-induced, and pathological, as well as we need to assess the fertility involvements of both sexes. As we know, hyperprolactin tends to interfere with the fertility because of the inhibitions of the dopamine. Okay, as well as the assessment of the anterior pituitary hormone, as they can coexist in certain conditions like in acromegaly because of the adenoma. I will cover on macroprolactin as this is one of the important things that or occurrence that may occur in a laboratory setting. As I mentioned earlier, macroprolactin referring to analytical hyperprolactinemia with prevalence of 12.4 to 40%. It is increasing with age as it is stimulated by dopamine antagonists and respond to the physiologic stimuli, and it has a minimal biological activity and pathological function. The gold standard to measure macroprolactin by size exclusion chromatography, but we have an affordable approach by utilizing the polyethylene glycol, PEG. There are a few issues on PEG methodology of PEG approach, but before we go into the issues, I would like to attract or address on the interpretation. We have two options, whether you want to interpret it as PEG precipitation ratios of more than 60% or post-PEG prolactin recovery of less than 40%, which signify presence of macroprolactin. Now we move on to the issues in relation to PEG method. It has a large variability in diagnostic criteria, so we can appreciate if we go to a certain protocol, it has a different cutoff. Okay, so I would say it as arbitrary, and obviously there will be a lot of available protocol, and we have intermethodology discrepancy despite standardization. Also, reporting as in percentage it has a lacking in diagnostic specificity, and it was suggested that or advocate to have an absolute value in reporting with modified reference range based on the normal prolactin sample precipitated with PEG. Spurious results may occur post-PEG as those who have been precipitated with patients who have elevated GGT, as well as in IgA macroprolactin may not precipitated with the PEG. Lastly is because of interference by hook effect, gamma or heterophil antibody or biotin, which may cause a costly low. So the strategy to identify macroprolactin in a laboratory sample, they have come to the three strategies. You can opt any point or which is suit with the lab. Okay, assessment of macroprolactin in asymptomatic hyperprolactin, assessments of macroprolactin in moderate elevations of prolactin without identifiable cause, or we can just screen macroprolactin in all hyperprolactinemia sample. Last, I will focus on the guide and recommendations in interpretation. So before we proceed, I would like to enforce or highlight on the important things that you need to address or to equip yourself before interpret the results, which know what is the clinical indications of the test. You must justify the suitability of the test and knowledge on the pathophysiology of the endocrine system, what are the available options and needs of the tests, and which you want to provide single or dynamic testing, and advantages and limitations of tests, factors that affect the measurement. For somatotropic axis, we will discuss on the growth hormone as well as the IGF-1. Growth hormone, obviously, it is synthesized by the anterior pituitary, which is a 191 amino acid polypeptide hormone. It stimulates liver to produce insulin-like growth factor indirectly, and the release controlled by GnRH and somatostatin. The concentration varies and undetectable at times. It has sporadic bursts that usually occur at sleep and last about 1 to 2 hours. Stimulated by stress, exercise, hypoglycemia, fasting, injections of certain amino acid, and it is inhibited by increase in blood glucose. It is not suitable to use as first line for acromegaly workout, but it is an assistance tool in growth hormone suppression test if IGF-1 is positive. And it's as well subjected to hook effect for patients who have a big adenoma, which require dilutions to mitigate the hook effect. For IGF-1, it has a considerable amino acid sequence homology with insulin, and it shares some of its action. It able to provide negative feedback at the pituitary and hypothalamus levels, whereby it stimulates release of somatostatin. And it is a good screening tool for suspected acromegaly case. Box 9.1, just to illustrate to you the metabolic actions of growth hormone. It has a ketogenic, divertogenic, as well as anabolic effect. Pathophysiology, obviously, we will look at the hypofunction as well as the hypofunction. Allow me to start with the hypofunction. It is uncommon, but it is one of the important causes of growth retardation, especially in pediatric. And growth hormone level in normal children may be undetectable. And that's why random low level of growth hormone does not signify that the patient have a growth retardation. Okay, so the clinical features, if it's pediatric, there will be absolute growth retardation progress. And for adult, there will be increase in fat mass, decreased lean body mass, osteopenia, dyslipidemia, insulin resistance, as well as glucose intolerance. So for hypofunction, 95% is result as from the excessive growth hormone by the pituitary tumor. Acromegaly can co-feature for men type 1, and the clinical diagnosis should be made by demonstrating failure or suppression biochemically. So clinical features, it depends on the growth hormone secretion. So we have somatic changes, metabolic changes, as well as the local effect. Laboratory approach, I following the pathophysiology. So for hypofunction, we will look at the serum IGF, insulin growth factor 1. Normal level exclude acromegaly or gigantism. However, in elevated or discordant with the clinical presentation, we would like to proceed with the dynamics testing. We can opt for a growth hormone suppression test or growth hormone 5-point day curve, especially in diabetic patients. I will further elaborate on this. Meanwhile, for hypofunction, we can opt for growth hormone or serum insulin growth factor 1. Okay. For growth hormone, concentrations of more than 5 micrograms per liter in single sample exclude significant deficiency. And it also can be assessed by dynamic testing using insulin hypoglycemic test, where the induced hypoglycemia of less than 2.2 is good enough to demonstrate the evidence of growth hormone deficiency by results of less than 5 microgram per liter. For serum IGF-1, if the suspicions are because of the pituitary, if a patient have 3 pituitary hormonal deficiency, a low IGF is a diagnostic of adult growth hormone deficiency. But for patient who has less than 3 hormonal pituitary hormonal deficiency and low IGF level, we should proceed with stimulus test to confirm diagnosis. What is growth hormone suppression test? The rationale is to diagnose acromegaly. So we will appreciate the fail of suppression upon glucose load. And another utility is for assessment of post-op acromegaly patient, assessments of the residual disease, which usually done 12 weeks post-op. And we must understand on the dynamics testing, we know how to prepare a patient, what are the procedures involved in order to have a reliable result for a reliable interpretation. Okay, so we should know how to prepare the patient and the procedure. Okay, so the patient should be fast overnight, and we need to control the hypoglycemia prior to fasting. And then minimum is about 10 hours fasting. And we will take the baseline glucose, growth hormone, and IGF-1. And we will introduce the glucose load by 75 oral glucose. And we will collect the parameters. We will collect the sample for glucose and growth hormone analysis every 3 hours for a 2-hour duration. You may refer to this table to have an obvious outline or obvious interpretation on the procedure. So how to interpret? Okay, a normal response, the growth hormone should be less than 1 microgram per liter. Meanwhile, for those who patient post-op, it's less than 0.4. Please remember the risk of false positive or GDT results that may contributed by a patient who have a poor controlled diabetes mellitus, has a nutritional disorders, or patient who has a renal disease and liver failure. For growth hormone 5-point day curve, it is suitable for patient who has poor controlled diabetes, okay, versatility of growth hormone, and 5-point day curve have a good correlation with a previous growth hormone 13-point curve. So we must know the preparation and procedure. So what the difference is that after the baseline at AM 8 hours, okay, patient will allowed to take breakfast and usual medication, and patient must avoid vigorous exercise or food other than the designated time point for them to have a food, and a blood sample will be collected every 2 hours. Okay, 10 a.m., 12 noon, and at PM 2 p.m. and 4 p.m. Okay, so the time, the duration times for growth hormone 5-point day curve is about 480 minutes. Okay, so interpretations, they look at the average mean growth hormone across the 5 times collection times. If the value of more than 1, it signifies active acromegaly. Now we move on to the last axis of today's presentation, corticotropic axis, which covers on the cortisol as well as the ACTH. We cover on the also hypofunction. ACTH secreted by the pituitary in response to the hypothalamic CRH, and cortisol exert a negative feedback through inhibitions of the CRH, thus cause decrement in the ACTH level. Cortisol, it is secreted by the adrenal cortex, especially in the zona fasciculata, as a response to stress. And 95% of it are protein bound but transporting, and it's excreted unchanged in the urine and has a diurnal pattern. Box 10.0 illustrate or explain or list the principal physiological functions of glucocorticoid. It's cause increase in protein catabolism, hepatic glycogen synthesis, hepatic gluconeogenesis. They also inhibit ACTH secretion, as I mentioned earlier, and has a permissive effect on the water excretion. It sensitizes arteriole to the actions of noradrenaline, and it involved in the maintenance of the blood pressure. It inhibits the inflammatory and immune response, and it inhibits the bone formation. Okay, we go on the hyperfunction. Obviously, it will be a Cushing syndrome. Cushing syndrome is the umbrella or the collections of disease spectrum. We have true Cushing syndrome and pseudo Cushing syndrome. For true Cushing syndrome, it's further divided into exogenous, that usually iatrogenic, and endogenous cause, which are divided into ACTH dependent and ACTH independent. The classification is very important, and the identification which are the possible pathology is based on the laboratory investigation. So it's very important for us to know the approach in identification of the possible causes of Cushing syndrome. On my right hand side, the diagram simplify on the clinical features of clinical presentation of a patient with a suspected Cushing syndrome. For example, hyperglycemia, personality change, moon face, fat deposit at the back, thin extremities, and then patient may come to us with osteoporosis, opal striae, thinning of skin. Okay. Okay. The approach in Cushing syndrome is by the screening test to identify or to illustrate the patient is having hypercortisolism, and we will proceed on the elucidations of the cause. Okay, so how to illustrate a hypercortisolism state? We have a few options, whereby by 24-hour urinary cortisol or midnight salivary cortisol, which minimum that we need to depend on the level is based on a minimum 2 value. Okay, then we will can proceed with the overnight DEXA suppression test or 48-hour low dose dexamethasone suppression test. Okay, if we go to the urinary cortisol, 24-hour urinary cortisol, okay, the normal excretion or expected excretion is about 300 nanomole, and it may pose a false positive result because of improper timing of urine collection with concomitant use of diuretic, high salt intake, and pseudo-Cushing presentations like depression, obesity, or alcohol abuse. Okay, for midnight salivary cortisol, okay, the normal result is less than 2 nanomole. Okay, and it is not we can appreciate on the disruptions of the diurnal rhythm. Okay, and it can be collected by patient at home and is not cumbersome. Okay. I would like to draw your attention on the differences between the overnight DEXA as well as the 48-hour low dose. Okay, so if you can see, overnight only use 1 milligram DEXA. For low dose DEXA suppression twice, it's occur throughout 2 days with interval in between of the medication given every 6 hourly. Okay, and the blood taken should be at 9 a.m. in the next morning with expected normal value of less than 50 nanomole per liter. If there is increment more than 50, then we suspect a failure of suppression. Okay. For elucidation, of course, this is very important because we want to look at whether this is ACTH dependent or ACTH dependent. Okay, so obviously the plasma ACTH level is very important, and we should interpret it accordingly. Okay, if it's low level, possibility of adrenal in origin. If it's elevated, then we can see whether it is a pituitary dependent Cushing disease or ectopic CTH. So how are we going to delineate this? So we can use a high dose DEXA medicine suppression test for corticotrophin releasing hormone. Okay, so what is high dose DEXA medicine suppression test? We give 2 milligram DEXA every 6 hourly for 2 days, and we will measure the cortisol level after completion of the 48 hours at 9 a.m. Okay, there will be a suppression in Cushing disease of the value usually less than 50% from the pre-treatment value. However, if it's adrenal in origin or ectopic ACTH, there will be no suppression. For corticotrophin releasing hormone, it is useful to differentiate between Cushing disease and ectopic ACTH or adrenal tumor. We give CRH of 100 microgram via intravenous, and we measured plasma ACTH and cortisol before CRH and 60 minutes after CRH. So for Cushing disease, okay, there will be increment of plasma ACTH by 50% and increment of cortisol 20%. However, for adrenal tumor or ectopic ACTH, there will be no response. Okay, now we move on to the last session of hypofunction. I will cover on a primary adrenal insufficiency. So it results from intrinsic adrenal failure, cause decreased glucocorticoid, mineralocorticoid, and androgen. The decreased hormone level will lead to increase in upstream mechanism in an effort to increase adrenal hormone production, and we can appreciate by increment of the ACTH by the pituitary, CRH, and vasopressin by the hypothalamus. Patients with primary adrenal insufficiency have increased for adrenal crisis because of the low production in the mineralocorticoid and glucocorticoid. We can divide the classifications of PAI into primary, secondary, and tertiary. Okay, so primary, the problem would be the adrenal. Secondary and tertiary, the problem arises from the pituitary and hypothalamus respectively. So table 1.1 simplified on the causes and clinical features of primary adrenal hyperfunction. So the commonest cause would be glucocorticoid treatment and autoimmune adrenalitis and tuberculosis. And the last common which are adrenectomy, secondary tumor deposit, and so on. So secondary tertiary adrenal insufficiency. Okay, as I mentioned earlier, secondary is clearly insults in the pituitary disease. Tertiary caused by disorder of the hypothalamus, which impact the synthesis of CRH and subsequently leads to reduced release of VCTH secretions from pituitary gland. Okay, so the causes of secondary, it's either come from the pituitary or hypothalamus. Okay, the list as such. Okay, if you look at the table on my on the right hand side, you can see that the differentiation of primary and central. So most common causes for primary is autoimmune, but for central, it's more of a chronic glucocorticoid therapy. Both can have a low cortisol, but the differentiation is in the aldosterone. Primary, we have low aldosterone, central, normal aldosterone. ACTH will be high in the primary, low in the central causes. And for clinical features, the symptoms is much more severe in primary as compared to central. Okay, so a bit on adrenal crisis. It can be a first presentation of an adrenal insufficiency, and it more likely to occur in primary adrenal insufficiency. And patient may present with acute abdominal symptom, delirium, obtundation, hyponatremia, hyperkalemia, hypoglycemia, and fever. Another remarkable presentation is shock, hypotension, and volume depletion. So the laboratory investigation, obviously, first line cortisol, and then we will proceed with the shock symptom test, okay, to elucidate the possible, to screen as well as to guide us to possible causes of the hypocortisolism or hypoadrenalism. Okay, so the rationale for the test, the low level will be expected in the primary adrenal or secondary adrenal insufficiency. So, as I mentioned earlier, we must know how to prepare and the procedure. Okay, the patient needs to withhold any spirit movement for 24 hours prior to the test. Okay, and patient may be treated with DEXA. Okay, and the baseline will be collected in the morning, okay, for cortisol as well as ACTH. IM or IV synectin will be introduced to the patient, and blood collection of cortisol will be collected at 30 and 60 minutes. Okay, if suspicions of CAH, then we will have additional tests that can be put in, is the measurement of 70-OH progesterone. Okay, so before we interpret, we need to consider a few things. Okay, based on the harmonization endocrine dynamics testing by AACB 2021, they suggest that each lab must have their own laboratory cutoff. Why? Okay, they mentioned that the concentrations of peak cortisol cutoff is AC dependent. For female, OCP raised total cortisol level because of elevated CBG. The use of historical peak of 550 nanomole per liter in a newer cortisol specific assay may result in false positive results. And previous requirement of increment of more than 250, it also can be redundant, as a normal individual with high baseline cortisol will not achieve the increment. This is the suggested cutoff based on assays. You may look at it in the guideline. It is available online. Okay, so you can see that the cutoff will divide according to gender as well as in populations of possibility of oral contraceptive pill, which cover on the acceptable peak for the healthy subject. Okay, at the time point of 30 minutes to 60 minutes. And it also covered on the 4 cases that are in the indeterminate zone. Okay. So the interpretation for the adrenal cortisol as such. So for normal short synapton test, okay, the stimulated level will be exceeded with the minimum cutoff specified for the assay. And for abnormal, yes, it is the below with the expected cortisol cutoff specified for the assay. So additional on the interpretation for the 21 hydroxylase deficiency by the measurements of the 70 OHP as illustrated in the table. Lastly, I would like to conclude increasing prevalence of pre-diabetic and overall diabetic patients in Malaysia warranted and efficient, reliable tools for screening, diagnostic, and monitoring for early recognitions and interventions. Hyperprolactinemia is common occurrence, and salient notes of approaching such cases is vital to accommodate in the effectiveness of patient management. And lastly, endocrine result interpretation is important in patient management. Adequate understanding on the physiological basis, pathophysiology, acknowledging the advantages, limitations, and suitability of the test are the pillars for good results interpretations. With that, these are my reference, and thank you very much.
Thank you, Dr. Munira. Can you hear me, Dr. Munira?
Yes, loud and clear. Can you
All
hear
right.
me?
Yes, clear. Thank you, Doctor. I believe the lecture is not only comprehensive, but also very updated on endocrine testing in the lab. Clearly, we have a lot of take-home messages to our lab workplace, so we can improve and suggest to provide better service for the healthcare. We now open the floor for any questions from the participants. You can type in the chat box or raise your hands to speak directly to Dr. Munira.
I think can I just highlight on the few questions that come up, and I just answer it by typing, but I would like to share with everybody. So the first questions is what is the overweight 85 percentile or obese 95 percentile means? Okay, if we refer, this is referring to the growth chart of a child. So in Malaysia, if I'm not mistaken, we have a few chart that are ranging from normal child to special need child. So you may refer there. And if we look at the CPG type 2 on table 2.2, all these information are actually gathered from the American Diabetes Association Standards of Care in Diabetes 2020. So I hope it's informative to Mr. Goh. Next question on measurements unit of A1C. Our lab have been used dual unit reporting since 2015, almost 7 years. Is there any nationwide initiative to standardize to only one reporting unit IFCC? I'm afraid I cannot answer that as I'm not a representative from Ministry of Health. I only govern in Ministry of Education, especially in my center. So, but I would answer on behalf of the CPG. If you refers to my slides, CPG actually propose we can report to any of the reporting units or combinations of all three. All three is actually inclusive on the estimated average glucose. Okay, next, last questions that I received on the Q&A box. Okay, how does elevated GGT affects on macroprolactin? Okay, The answer also in my slides is actually the GGT cause increased precipitations of the monomeric prolactin, and it actually leads to a false positive post-PEG result. So it caused a spurious result, meaning that if you have patients that have elevated GGT, you must interpret the post-PEG result with caution. Okay, thank you, Prof. Pavai, for helping me answer the question as well. I think, is there any question? Because that is only the questions that I have so far.
Yes, we have one question from Siti Suhana.
Okay.
From Siti Suhana, can you ask your question directly to Dr. Munira? Please unmute, yeah? Puan Suhana? We can't hear you, Puan Suhana.
I think we have another question for up. Oh, she doesn't have any question. Accidentally clicked the
Okay.
icon.
Okay, we have two more questions, if I'm not mistaken, from the Q&A. Oh, I see. That's her.
Okay.
All right,
Yes.
right. All right. Okay, I have one question for you, Dr. Munira.
Okay.
What's your take on the NAFLD current challenges and future directions in the Malaysian public healthcare settings? Can you share your take on it?
Okay, so in my opinion, I think because I also participate in the MACB meeting with the respective counterpart from Dr. Rosmawati, Professor Rosmawati from UMMC. So from there, actually, I already incorporate the FIB4, the calculated measurement in our liver function test panel. However, that one I cannot fully utilize yet because that one still under trial. So once it's okay, then I will incorporate it with LFT. However, recently I think my colleague have a meeting with our counterpart from endocrinologists as well as from primary care medicine, and she needs to update me on that. But however, for my point of view, yes, I actually incorporate the score in order to facilitate the clinicians in screening the NFLD or MAFLD in our center. And for me, it's a good tool, and it's a very simple tool. It's only calculated, and you actually able to offer the test and because if you look at the patients who underwent follow-up, those are actually routine tests. So it will not incur massive work process. So for me, it's a goal. Okay, thank you. That's all from me.
Right, hopefully it will be a very smooth journey.
Inshallah.
Are there any more questions from participants? You can raise your hand and we will allow you to ask directly.
I think still morning, still early in the morning.
First lecture.
Yes, and quite heavy.
Yeah, it's quite comprehensive, but very, it's very fruitful.
Yeah, Alhamdulillah.
Any more questions? All right, if there are no more questions for Dr. Munira, I would like to thank her for her very comprehensive lecture. And I'd like to wrap up the session and remind all participants to fill in the feedback form before you leave this session. Don't forget to leave the session and click on the next session box to join Dr. Posey Wei for her lecture. And before that, we will enjoy a commercial video which is up next.
Thank you.
All right, thank you, Dr. Munira.
Okay, have a nice day. Bye-bye.
All right, Assalamualaikum. Waalaikumsalam.
Today, more than ever, the importance of accurate and timely diagnostics is clearly understood. The journey from blood collection to the final test result, however, requires the highest level of dedication, expertise, and diligence of the laboratory staff. To support you in this, Roche has developed innovative integrated solutions renowned for quality and excellence. Cobas Pure Integrated Solutions is the newest member of the Cobas family of systems, designed to deliver excellence, while at the same time simplifying your daily work. Cobas Pure combines clinical chemistry, immunochemistry, and ISC testing on a footprint of just 2 square meters, giving access to our broad menu of more than 230 parameters, including many unique high medical value assays to labs which have to deal with limited space. To simplify daily operation, Cobas Pure comes with new features that minimize the hands-on work for the operators, thus saving precious time. To enable simple and effective work for network organizations, Cobas Pure provides fully standardized results and operation to Cobas Pro Integrated Solutions, the latest analyzer from Roche designed for larger labs. Because simplifying any step of the journey while ensuring excellent quality can help deliver faster and more accurate diagnostics. Simplicity meets excellence with Cobas Pure Integrated Solutions.